It's me, Dr. Mohammed Kazafi. I am presenting one more very important topic in front of you people, which is the name is ossification of the posterior longitudinal ligament, and how we are treating it, how we are dealing it. It's me, Dr. Mohammed Kazafi. You are watching Dr. Mohammed Kazafi Views, and you know that there is a ossification. Ossification posterior longitudinal ligament is an idiopathic cervical spine anomaly that is commonly cause of the cervical myelopathy in the Asian population. And the diagnosis is made with the lateral radiograph of the cervical spine. CT scan is the study of choice to determine the extent and the thickness of the ossification. Treatment is observation in patient with minimal symptom, and the surgical decompression followed by stabilization is indicated for patient with myelopathy. For cervical ossified longitudinal ligament, I want to present one case as an analogy. This is the 75-year-old male presented with the progressive weakness in his upper arm and the lower extremity, although most pronounced in the hand, and he further report numbness, tingling, and inability to perform fine motor tasks, and he additionally has been having increasingly difficulty with gait and balance function. His symptoms have been progressively worsening over the last 12 months, and he denies any recent trauma. Past medical history was not significant, and the hypertension, type 2 diabetes mellitus is since 10 years, since 20 years, and examination shows there is a reduced range in the cervical motion and electric shock extending down his spine during passive neck flexion. Wasting of intrinsic hand muscle bilaterally, and increased tone in bilateral lower extremities, quadriceps and a grade 4/5, affecting extensor more than flexor in upper extremities and the most evident in the hand, and effect flexor greater than extensor in lower extremities. Reflexive brisk hyperreflexia in upper and the lower extremities, and the severe gait ataxia. Differential diagnosis, definitely my provisional diagnosis was definitely there is some lesion in the cervical spine. But if we go for the differential diagnosis, then we have to consider the cervical spondylotic myelopathy, cervical stenosis, because of the, now you can say, or I can say, there is a ossified posterior longitudinal ligament, a neoplastic may be metastasis, and the spinal cord tumor, vascular, because of the vertebro-basilar insufficiency and the cervical instability, such as the C1, C2 subluxation, and the others such as the amyotrophic lateral sclerosis and the syringomyelia, vitamin B12 deficiency, or Chiari malformation. Regarding the investigation, definitely the serial X-rays has been done and conducted, lateral, AP, oblique, and then CT scan. It was suggestive for there is a ossification of the posterior longitudinal ligament, and as we know, the CT scan is a investigation of choice here with us, and definitely there is and I want to show you here a picture. You can appreciate this. If you see this, which is suggestive for there is a ossified posterior longitudinal ligament. This picture I took from one book, because this book shows appropriately we can understand both, and you can see the ossified posterior longitudinal ligament how behave, and you can appreciate here if you want to see there is a this is the posterior to the vertebra in the canal, in the anterior part of the canal. You can appreciate there is a ossified posterior longitudinal ligament. And in this picture, if you see, this is the MRI T2 weighted image, which is suggestive for the multiple degenerative disc herniation and beaking of the disc associated with the ossification of the ossification. You cannot confirm with the MRI, but you can confirm with the CT scan. Here in the sagittal view, you can see there is a hyperdense area, but in this T2 weighted image there is a hypodense area. But it can say a lot of things, but MRI is important to know the condition of the spinal cord and to see what is happening in the spinal canal. For further workup, what we can do, definitely we want to admit this patient. Once we admit the patient, then we will do the CBC, BMP, PTINR, APTT, X-ray cervical spine with and the dynamic views, and then CTA to map vertebral artery, and of course if secondary multi-level corpectomy, and definitely pathophysiology regarding that this posterior ossified posterior longitudinal ligament most commonly occur in the male, and which is the ratio male to female is 2:1 in there, and it contribute to 25% of the cervical myelopathy cases in North America and has higher percentage in the Asian population. This originates in the early hypertrophy of the posterior longitudinal ligament with accompanying punctate ossification, and creates early posterior longitudinal ligament, and these foci becomes like loci of the frank ossification in the posterior longitudinal ligament. So so the increased prevalence of the ossified posterior longitudinal ligament in the Eastern Asian, particularly among blood relatives, suggests a genetic predisposition. And the ossified posterior longitudinal ligament enlarge average of 0.4 millimeter per year, and its anterior posterior dimension and longitudinal expansion occur at the rate of 0.67 millimeter per year. So this is very important thing. We have to know that the ossified posterior longitudinal ligament enlarge an average 0.4 millimeter per year in its anterior posterior dimension, and longitudinal expansion occur at the rate of 0.67 millimeters per year. So it is very important thing. Two major mechanisms contribute to the neural injury in patient with the posterior longitudinal ligament: direct mechanical compression and indirect ischemic injury. There are four types of the ossified posterior longitudinal ligament. The segmental variant, located behind the vertebral body, does not cross the intervening disc space, and the continuous type 27% extend from vertebra to vertebra and traversing the disc space, and the mixed form is 29% and simultaneously include with the continuous and segmental element with escape areas, and the localized form 5% is localized to the disc space. So there are four types of the ossified posterior longitudinal ligament, which you have to understand. And the two major mechanisms contribute to the neural injury to patient with the ossified posterior longitudinal ligament. One is a direct mechanical compression and other is a ischemic injury. And as I mentioned, there are four types of the ossified posterior longitudinal ligament. One is the segmental variant, which is 39% located behind the vertebral body and does not cross the intervening disc space. And the continuous type is a 27% extended from the vertebra to vertebra and traversing the disc space. And the mixed form, which is the 29%, and simultaneously include both continuous and segmental element with skip areas and localized from 5% and is localized to the disc space. Here, actually, as I mentioned, that there is a demographically it is involved in the Asian, and most common is not limited to the men or women, but men are more pronounced than women, and the anatomical location most commonly level are between C4 to C6. And 95% of the ossification is located is you can say spine, cervical spine. And the pathophysiology, as I mentioned there, but it is unclear but multifactorial, associated with the factors such as the diabetes, obesity, high salt, low meat diet, or the poor calcium absorption, and we can say the mechanical stress on the posterior longitudinal ligament. Ossification of the posterior longitudinal ligament is a process of fibrosis, calcification, and ossification of the posterior longitudinal ligament of the spine. And the ossification in we can say the ossified posterior longitudinal ligament causes the ligament to become rigid and grow in size, which may decrease the precocious space in the vertebral canal already occupied by the spinal cord and its covering. So the OPLL, or the ossified posterior longitudinal ligament, is an idiopathic cervical spine anomaly that is commonly cause of the cervical myelopathy in the Asian population. And the CT scan is the study of choice to determine the extent and the thickness of the ossification. As I mentioned, the exact pathogenesis of the ossified posterior longitudinal ligament is unclear, but ossified posterior longitudinal ligament is often associated with the several other entities and diffuse idiopathic skeletal hyperostosis. If there is a condition, a person is suffering diffuse idiopathic skeletal hyperostosis, you can find other areas the osteosis there, and the same we can appreciate here in the posterior longitudinal ligament. But the ossification of the ligamentum flavum may be associated with the ossification of the ligamentum flavum, and this may involve or more involved in the lumbar area and the ankylosing spondylosis. The diffuse idiopathic skeletal hyperostosis may be seen in up to 12% of the elderly male Caucasians, with the ossified posterior longitudinal ligament seen in about half of these, suggesting the incidence among Caucasians and maybe higher than the other. But the location, definitely 75% it involves cervical area, and in cervical area mostly C4, C5 area, C4, C5, C6 area more involved, and then thoracic area 15% involved, and then lumbar area which is 10% involved. So according to the classification, the most commonly used classification is the proposed by the investigation committee for ossification of the spinal ligament, which is created by the Japanese Ministry of Health, Labor and Welfare. And they mentioned there are the four kinds, which is one is the continuous. This is a long lesion extending over several vertebral bodies. It means it involves and several vertebral body I will show you here, as I mentioned you before, but I will show you again here. If you could appreciate this, there is a longitudinal ligament in a several vertebrae involved long continuous. So we can say this is the continuous, and here this sagittal section is telling us in detail lot of. So yes, I just want to mention here that is sorry. If you can appreciate this is the longitudinal connectivity in the last picture, and now I want to show you, or I will just want to explain you. There is a segmental, one or several separate region behind the vertebral body. There is one lesion or maybe several lesions. This is called segmental, and third one is called the mixed, a combination of continuous and the segmental type, and the localization, focal, subscribe, and a circumscribe, mainly located posterior to the disc space. So the radiographic feature continuous ossification of the posterior longitudinal ligament is visible as linear density posterior to the vertebral body cortex within the vertebral spinal canal, and the CT is the best modality to despite ossification of the posterior longitudinal ligament, and often obtained for this purpose in case of cervical spine stenosis. Ossification can appear continuous and spanning multiple segment, and the segmental discontinuous along vertebral bodies, and the localized span just the disc level, and the ossification appear confluent but often thick. So now here the how X-rays are behave, I want to show you. You can appreciate how the X-ray can behave, and you can see this is the X-ray cervical spine lateral view, and here you can see or you can appreciate there is a hyperostosis here in that area, and which is suggestive for the OPLL. So CT is the best modality to despite the ossification of the posterior longitudinal ligament is often obtained for this purpose in case of cervical spinal stenosis, and ossification can appear continuous spanning multiple segment, and the segmental discontinuous along vertebral bodies, and are localized spanning just the disc level, and the ossification appear confluent with but often thicker and denser than the critical bone of the vertebral body. The third modality which we can check, which is called the MRI, and how MRI can show, I want to show you. Definitely you can appreciate here there is the anterior and posterior double crush, or we can say the combined crush, and from the posterior element also ossified. I can say this is the ligamentum flavum, also hyperostosis or ossification, and the anterior you can appreciate here the significant, and it is showing here like this. And if we want to see like axial, so here we can appreciate how the axial behave. Here you can appreciate axial. This is all hypointense area in the T2 weighted image of MRI, and which is in a general color you can say this is a black color, and it's ossified, which is shows hypointense in T2 weighted image. And here you can see this is this gray area or isodense, we can say this is the spinal cord, and how much pressure you can appreciate here, and you can understand how much spinal cord under total flattening of the spinal cord here. So this is the thing I want to show you. So MRI ossification of the posterior longitudinal ligament appears hypointense in T1, and T2 weighted images. And however, hypertrophy of the ligament without ossification can also have this appearance, and T2 weighted sequence are considered the most effective in the evaluation of the spinal cord compression due to both the ossification and abnormal signal intensity of the spinal cord. Treatment and prognosis here, the management can be range from conservative to the surgical removal, and the surgical option can include the anterior, posterior, or combined approach. An anterior approach, for example, plated multi-level anterior discectomy and the fusion anterior cervical corpectomy with fusion, may provide more direct decompression and best improve myelopathy, although may cause a greater soft tissue morbidity. And the posterior approach, such as the laminectomy and fusion and the laminoplasty, may be better tolerated in the older patient. And we cannot say that this is the option of choice, but definitely it depends upon what patient need, how patient need. As the patient need, you can fulfill the requirement of that patient. For example, if you want to go for them, and for example, if we want to manage, we can manage conservatively or surgically, but surgical option can include an anterior, posterior, and combined approach. So the anterior approach, we can put a plate multi-level anterior discectomy and fusion, or the anterior cervical corpectomies, or at multiple level or single level, or the maximum compression level with fusion, and may provide more direct decompression and best improve myelopathy. And the surgical and the indication of choice is myelopathy. So as we were talking about the treatment options, the conservative treatment observation is appropriate in patient without sign or symptom of myelopathy, and in those deemed high risk surgical candidate or non-surgical management include immobilization with the neck brace, or the steroidal or the non-steroidal anti-inflammatory medication, activity modification, and physical therapy also very important. And the surgical approach is selected based upon the degree of myelopathy and number of involved segments, sagittal balance of the cervical spine, and the surgeon preference and the experience. So the significant controversy exists in regard to the anterior versus posterior surgical approach for managing the cervical ossified posterior longitudinal ligament. Anterior surgery offers direct ossified posterior longitudinal ligament removal, typically though multiple level or multi-level corpectomies and fusion, and whereas the posterior procedure allows for we can say indirect dorsal decompression of multi-level pathology via laminectomies and plus minus fusion or laminoplasty. Laminectomy plus minus fusion may sufficiently decompress the cervical spine canal in patient with the ossified posterior longitudinal ligament if the cervical spine is stable and the lordotic curvature remains adequately preserved. In some patients, stabilization may be performed to diminish the evaluation of instability, whereas in other, instability may already be present. So, multiple level anterior corpectomy and fusion improved outcome have been reported in some series for the ossified posterior longitudinal patient underlying multiple level anterior corpectomy and fusion procedure. Combined anterior and posterior approaches and for a specific case with the localized server, anterior compression accompanied by the cervical canal stenosis, the combined anterior and posterior approach can be used, and the laminectomy or the laminoplasty simultaneously offer dorsal decompression and augment stability without the need for the incidental fusion. I want to present or mention the surgical technique regarding this patient, what we are doing. Or laminectomies alone can be performed, but posterior cord herniation is possible, especially if the ossified posterior longitudinal ligament causes a bulky anterior mass in the canal. Neuromonitoring include somatosensory evoked potential are established pre and post prone position lamina, and the spinous process are removed with a high speed drill, and the ligamentum flavum is removed, and any necessary we can say the foraminotomies are performed. So the decompression typically include C3 to C7 or at a minimum one segment above and below the radiographically compressed level, and because of the risk of the posterior laminectomy kyphosis, lateral resection should not be incorporated more than the medial and 25% of the facet on either side. So it is very important thing because the risk of the post laminectomy kyphosis, so lateral resection should not be incorporated more than medial 25% of the facet joint on either side. The facet joint, when we are operating over the facet joint, we have to take care to avoid the kyphosis. And the decompression typically include C3 to C7 or at minimum one segment above and the below the radiographically and a compressed level. It is also enough to decompress the situation. Laminectomy with fusion, in some patient prophylactic stabilization may be performed to avoid the evaluation of the instability, whereas in others instability may already be present. So following neuronal decompression, lateral mass screws typically 14 millimeter are placed by the drilling approximately 1 millimeter infero-medial to the insertion of the retrocaudal and mediolateral midline, and aiming the trajectory to the superolateral edge of the lateral mass, and the intervening joint are then decorticated with the drill, and the rods are placed and they screwed under minimal compression. I want to show you one picture of the book, and in this book it is mentioned very well and clearly. You can see here there is the 20-degree angle is mentioned, and you can see if you go straight perpendicular, then where you are reaching, and when you are going and you are taking 20-degree angle superior lateral, and where you can go. So this is the thing. If you follow this, and in the axial plane you can see, and when you are going lateral, how lateral. If you are going to lateral, then take 30 degrees, and if you are going superior, so you go 20 degrees from the perpendicular plane. And this may show you how you can use your angles to avoid injury to the neurovascular bundle here, and how you can manage. So I just take this from the book to show you, to present in front of you. For anterior corpectomy and fusion, the corpectomy is performed by drilling a longitudinal groove approximately 15 millimeter wide through the index vertebra and exceedingly 15 millimeter in width increasing the risk of the vascular injury and decreases the bony surface area to side in arthrodesis. The the ossified posterior longitudinal ligament is carefully dissected free of the ossified dura and either resected or thinned. Microscopic magnification is mandatory to assist in distinguishing the posterior longitudinal ligament from ossified dura, and that must be left intact. So, arthrodesis is then performed during an structural bone graft or interbody cage with the use of the anterior cervical plating to solidify the contracture. Arthrodesis is performed, and only for using the structural bone graft or interbody cage with the use of the anterior cervical plating to solidify the contrast, solidify the construct. And the regarding the anterior corpectomy and fusion, the ossified posterior longitudinal ligament is carefully dissected free of ossified dura, and either we can say either resected or thinned. Microscopic augmentation is mandatory, is very very mandatory, and to assist in distinguishing the posterior and longitudinal ligament from the ossified dura that must be left intact. Otherwise, this is the significant CSFD can then very difficult to control anteriorly. And the laminoplasty has classically then associated with lower risk of the post-operative kyphotic deformity, and we can say compared with the standard laminectomy. So the laminoplasty is associated with low risk of the post-operative kyphotic deformity, but definitely it is not challenging, but it is definitely a choice, and where you can apply this choice according to the condition of the patient is very very mandatory. As here and in the same manner, I want to show you the how the posterior plates are seen, and how the plates are, you can see. So I show from the same book, it is showing very well. I think you can appreciate very well here, because you can see there is a construct in a lateral view, or and this you can see how the screws are going, why we are using the superomedial approach, and how you can see the superomedial approach is using, and how the screws are going, and how the plate is looking from the posterior side, you can see here. And that's the way we are doing. And here this with this picture above, you can see here the how and too far lateral, and for example you are putting a drill breaking through the parts, and here you can see how it is going, and a two medial. So this is the ideal way where we have to go. Just it is mentioning you, okay, if you are going in this direction, what happened, and what could happen. So then I want to mention you now. I want to show you one picture of the same book, which is showing from the anterior corpectomy approach. And in the group A, you can see how the decompression, and then how you can see here the cage has been presented or applied, and how it look like, and 15 millimeter width is good enough to go. So people are asking how millimeter we go, how much width, how much long. So long, it depends upon the segment is involved. In the two segment involved, you can go two segment, or if they are not involved two segment, then you have to go in that manner. So this is the thing I just wanted to mention you here with this picture. I hope you understand. Actually, laminoplasty required drilling a partial through on one side and a complete rough on the other side, and enabling a hinge-like opening of the spinal canal, and followed by the placement of the bone or the metal implant stabilizers that are secured into place to maintain a canal expansion and cervical rigidity. The complication here and how we can avoid. Actually, awake fiber optic intubation and positioning are performed under continuous somatosensory evoke potential and the intermittent motor evoke potential monitoring to avoid cervical injury, especially severe myelopathy, and especially when you are doing for such a patient. And the complication of anterior cervical surgery include 2% and a 10% incidence of the we can say the quadriplegia, and up to 14% incidence of the nerve root injury. So the complication, you can say the anterior cervical surgery when you are doing, this is a 2 to 10%, and the 2 to 10% the incidence of the quadriplegia, and up to 17% incidence of the nerve root injury. So typically the C5 nerve root, and the continuous intraoperative somatosensory evoke potential monitoring limits morbidity associated with the cervical surgery for ossified posterior longitudinal ligament. The incidence of the CSF leak after anterior cervical OPLL resection is between 6.7 and 31.8%. If CT and a sign of dural preference are observed prior to the surgery, then intraoperative. So these are all I want to mention here, that the incidence of CSF leak after anterior cervical OPLL resection is between 6 to 7%, and 38% if CT if CT sign of dural preference on observe. So this is the very important things which we have to understand here. And in the meantime, and definitely I want to give you uh, one more photo of this book. It is very good photo which from the surgical point of view. Yes, you can see here how means we are you when you are going from the and the drilling and everything, how you can approach for posteriorly when you are drilling, and how much width you need, and how you are making the hemilaminectomy here. You can see this area we cut, this area, one area we have to cut full from this side, and then other area we have to make a hinge here, and then make a open door policy, and we have to check the dura should not stretch. If it is highly stuck with the ligamentum flavum or posterior ligament, this ligament, or anteriorly from the posterior ligament. So we, and this plates we can use here. This is a strapped plate, or if it is not available, then you can make a strap here, and then micro mini screws. You can see from the posterior when the plate is placed like that, how much space has been created here. You can appreciate how much space has been created here, and you can understand the how this hemilaminectomy can work. Actually, this kind of picture and and is easily I can show in front of the in the YouTube. Otherwise, on the YouTube, the blood if coming, they are trying to avoid these kind of picture, and they don't like we can show these kind of pictures. Yes, I want to mention one thing here. The fistula may be anticipated, allow this CSF fistula may be anticipated and allowing the surgeon to plan for the complex dural wound repair, and head elevation and lumbar drain may be employed post-operatively to minimize the pseudomeningocele formation, and posterior surgery is often contraindicated in the presence of the significant kyphosis, as removal of the posterior element may leave the cord tethered over the ventral disease. Here I want to just add few things. I just want to give a brief summary regarding the technique or use of technique. In my humble opinion, that interbody fusion without decompression indicated in patient with the dynamic myelopathy. There the dynamic myelopathy you can just interbody fusion without decompression. And theory behind this technique is that removing motion at stenotic level, trauma to the cord has been eliminated, and you can avoid the myelopathy in the future for a longer period of time. Anterior corpectomy with or without posterior longitudinal ligament resection indication is that the indicated in patient with the kyphotic cervical spine where posterior decompression is not an option. When we are indicating in patient with the kyphotic cervical spine and where there is a posterior decompression is never an indication, so and never would be the option. So the technique is one method to avoid a dural tear is to perform a corpectomy, and instead of removing the posterior longitudinal ligament, ossification of posterior longitudinal ligament from the dura, allow it to float in the corpectomy site. And it is also relieving very smart, means it is a smart move, and I am doing most of these things. This indication is my indication of choice. I am doing this indication more. But the other techniques such as the posterior laminoplasty or the laminectomy with fusion, for example, indication only effective in the lordotic spine, and it allows the spinal cord to drift away from the anterior compression of the ossified posterior longitudinal ligament, and considered a safer preferable approach due to the officially of the resecting the ossified posterior ligament of the dura from the anterior approach. So this is an indication here and only effective in a lordotic spine, and it allows the spinal cord to drift away from the anterior compression of the ossified posterior longitudinal ligament, and considered safer and preferable approach due to difficulty of resecting the ossified posterior longitudinal ligament of the dura from the anterior approach. But as I am doing anterior approach, when I am doing, I am not trying to remove ossified posterior longitudinal ligament and hardly or with full enthusiasm. I am the which is safely can come, it is good, and which is not coming, no need to remove this, because avoiding of the dural tear is a major important thing as compared to giving the dural tear with your with the some anatomical beautification you can get on the CT scan or MRI. Technique, we can say the fusion should be performed with the laminectomy to avoid the post-laminectomy kyphosis and the complication. There is a risk of the post-operative ossified posterior longitudinal ligament growth. Complication, and definitely every surgery has the complication, and this surgery also has the complication. So I want to mention in front of you, such as the recurrence of the ossified and posterior longitudinal ligament and we can say that the complete resection, even though leaving OPLL to float in corpectomy site, in both scenario the recurrence can happen. That's all for the posterior longitudinal ligament, in my humble opinion. I hope you will like it. If you like, just subscribe, support, and share. Yes, you know that the ossified posterior longitudinal ligament commonly present with the myelopathy and radiculopathy, and a spine provider should consider that ossified posterior longitudinal ligament in their differential diagnosis and their reviewing images if surgical intervention is pursued. Imaging based measurement and finding can help in choosing an anterior versus posterior surgical approach. So, and that's all. Thank you so much.